Request Dr. Jatinder Vai also come to the stage. So just Vardhaman was continuing with the phakic lens. I thought let me continue with the phakic and then later by Jatinder and also Navneet sir to continue with the IOL platform. So I think already Vardhaman has told about the advantage of, excuse me, not moving. Already Vardhaman has told about what are the indication and contraindication for phakic lenses. So where LASIK cannot be done, even with the patient with a very severe dry eye, even extreme steep and flat corneas, even patient with the stabilized keratoconus, you can really opt for them for phakic lenses. So these are the indication Vardhaman already told, so I don't want to highlight. But what are the contraindication? Always you should know when you are thinking about phakic lens. The history of uveitis, history of glaucoma, very important, entry chamber depth less than 2.8. Even if the patient is already started developing cataract, don't think about putting the phakic lenses. And very important, especially when you are thinking putting these lenses, pregnancy is a contraindication. Always we should tell the patient after the delivery, after cessation of lactation, after 6 months only they can plan for any of the refractive procedure. So the advantage of all these phakic lens, because it is far from the endothelium also. The one point I always tell, whenever you, whatever the vision you are going to get in phakic lens is always better than the promise, because of these lenses are always close to the nodal point of your eye. And also the one more advantage always, the other complication like with any of the refractive procedures like dry eyes, which is not going to happen with the phakic lens, and also it is a reversible procedure. So before starting, I think I want to again tell what are the A list for pre-operative checklist. Very important: subjective refraction, keratometry, antechamber depth, pachymetry, axial length, and white to white. Of course, all my patients refractive surgery, I prefer to do a cycloplegic refraction. Those who are wearing soft contact lens, I tell them to discontinue for 4 to 5 days. Those who are wearing RGP, best 1 week to 2 weeks is ideal for them to come back for the refraction. Coming to the keratometry, really posterior curvature is not at all important. Normally, even those are having a good autorefractometer which has been calibrated, that keratometry reading is more than sufficient. Ideally, is optical biometric keratometry is more than sufficient for taking a K1, K2. So posterior K will not alter overall size or shape of the phakic lenses. Coming to the antechamber depth, that has to be minimum 2.8. So how you calculate? That is from the endothelium to the anterior capsule. So there are a lot of equipment really measure the AC depth, but I prefer to do with off scan. But most of us are having ultrasound. Always when you're doing the ultrasound, always you should remember to detect the Pachy value. So always deep antechamber depth or shallow antechamber depth always helps to determine the appropriate model for the particular lens. Probably I can say ACD is the only determinant which could prevent patient from getting the phakic lens. So coming to the ACD, this is the one of the study we did with the different machine. If you see here, with the A scan and with the IOL Master 700, almost the results are quite similar. You can see compared to. So normally I don't take from IOL Master 500 or even Pentacam is not that reliable when you are thinking about the ACD comparison. So even ASOCT, I do have got a Visante OCT which gives a quite similar ACD when compared to the A scan. So coming to the white to white, probably the single most important measurement which has for success for the procedure. Always you should take 2 to 3 reading. What I do in my hospital, normally I take white to white. I tell my co-consultant, after that you go and take, then we compare the readings, make sure that which is close to each other. Because what will happen if you have got a oversizing, normally you will have a higher wall leading to glaucoma, or if it is higher sizing, the chances of cataract will be very, very high. So this is again a small comparison what we did. See, we did along with the digital calipers, and also we did in comparison with the off scan also. results are quite similar. But when you see with the Visante, but Visante has given a very good ACD, but coming to the white to white, it's giving a overreading. So always what we do normally under the microscope, we take them to the OT and we do. See, just again, there are three important points when you are doing this white to white. You are having outer limbus to outer limbus, mid limbus to mid limbus, clear cornea to clear cornea. These are the 3 points always we should remember. But always, as I said, that patient must be there in supine position under the microscope, put a drop of anesthetic, always measure white to white horizontally. This is very important. Don't measure them vertically. Always measure them horizontally. But I do, because of my long experience, I measure from clear cornea to clear cornea using a digital caliper, my take home message. So always pre-op observation, you should always look for any hike in the IOP. Always look for the vault also. So what exactly is this vault? Vault is the distance between the posterior surface of the phakic lens and the anterior surface of the anterior capsule. What should be the ideal vault? Is around half a corneal thickness to the 1.5 corneal thickness. That is between 250 to 750 micron is the ideal vault for you phakic lenses. So what are the possible complications? As I already told, you may have low vault, you can have high vault, you can have a refractive surprise, you may have increase in the intraocular pressure, you may have a iris chafing, and even sometimes with a poor corneal healing. There's a small video actually just to share with you. Before acrylic phakic started, for 4 years we are with the company. First we implanted 500 lenses, then we came to know the results, and I don't want to again and again tell, because there are some of the company secrets. But what we felt that the lens what is being provided by the other companies, all are hydrophilic lenses only. Even though it is Collamer coated, after 1 year of implantation that Collamer coating goes back, and in the end hydrophilic intraocular lens is the lens is going to stay inside your eye. So if you have got a good ACD, I don't think so. Definitely we have been doing this lens almost 10-12 years. Absolutely there is no problem at all. See how I do, how everybody does the marking. Very simple. I think loading, I think already Vardhaman already told. Nowadays Acryl has come up with their, this is my older video, has come with their preloaded system. So just preloaded system, just you turn, just push it inside. There is no headache, only directly from the company the overall lens will go inside. As Vardhaman said, that very easy to implant. In my overall career, I never had any chance of flipping the lens inside the eye. Absolutely no chance, and it's quite easy to implant. Probably I think those are most of us here sitting here, all fantastic phaco surgeons. I think for you it is, even with the one patient experience, you can make it the best of the results. But again, pre-op evaluation is the key. White to white ACD, I think you have to keep it. If your pre-op workup is very good, then I think the procedure itself is very simple. We have only out of around 500-600 patients, 1 or 2 patients might have developed cataract, and very easy to remove, and again you can do the cataract surgery quite easily. You can see here even the rotation is around 15 degrees, so you need not have to, once you inject, normally design the lenses also so well. And again I want to tell, Biotech has spent their most of the time in researching this product. The product is really, really good. So this is about the video. These are the features. I think already Vardhaman had told. All the online version and offline mobile also available, and also no chance of flip and rotation. These are the nomogram. This is how you have to order for the lens. This is our experience at 200 eyes. Patient came for follow-up for 1 week, the 1 month, 3 month, and 1 year and second year. This is the model. Different models are available depending upon the patient's values. So again, I am having some time. So mean average, see, if you see here, we have done from 18 years till 45 years, and spherical equivalent of minus 14 diopters. So corneal thickness also we measured. We looked at the axial length, ACD, and mean keratometry. So most of in our case series, 51% of the patient had that refractive error between minus 10 to minus 15. Few of them are between minus 15 to minus 20. As Vardhaman said, that they can also customize and give you the lenses any power. This is how the post-operative spherical equivalent. If you see, in 46% of the patient have got a residual refraction of minus 0.5 to minus 0.01. And again, the wow effect in phakic lens is amazing. When I was going through the previous company, that ICL, almost around 14 years before, a lot of people used to shout at me, what you're doing? Nowadays, the era has come that everybody is doing phakic lens, something ultimate. So this is why, because of the wow effect, even patient with a 660 vision with a very high myopia, if you implant, then suddenly they are going to get the vision of 618 or 612 part. Again, this is because of these lenses are close to the nodal point of your eyes. So coming to the IOP stability, if you do all your pre-op workup, IOP is not going to increase also, you'll have a good results. Coming to the safety also, the patient achieving post-op uncorrected visual acuity equal to the pre-op best corrected visual acuity. Endothelial cell count was very, very less, minus 3.51 plus or minus 9.69. So 8 patients had an initial raise in the IOP which was controlled by medication. Spherical requirement is minus or within 1.5 diopter in 100% of the patient. None of the patient in my case series except one developed cataract, and because he was a diabetic patient, and then really required for explantation. These are our few experience with the acrylic phakic toric 200 patients. The range, the patient age is between 20 to 39 years. So this is the overall model with the toric. But if you see here, refractive astigmatism, pre-op astigmatism to post-op astigmatism, in 80% of the patient had a astigmatism less than 0.25. That means the rotation is not at all there. So more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. Coming to the rotational stability, 86% had less than 5 degree rotation, all had less than 10 degree rotation. In conclusion, acrylic phakic and acrylic phakic toric phakic lenses are very safe, effective for treating range of myopia and myopic astigmatism. And even we have been now started implanting patient with a -2, -3 diopter up to -4 diopters too. Short and easy learning curve for cataract surgeons. Quality of vision is always better than promised. Long-term follow-up studies are needed in order to evaluate the incidence of cataract and endothelial cell loss. I invite everybody to my hometown Udupi. We will be doing the Karnataka State Ophthalmic Society Conference 22, 23, 24 November. Thank you one and all.
Nice presentation. Just one question related to the surgical. How much dilatation you need before putting, if it is a very big full dilatation or semi-dilatation, what is your preferred?
So actually initially now also I need a full dilatation. That is the first criteria for me, because your comfortability is a must. I should not be rubbing or the iris that much. Full dilatation is very important. Last time in one of my live surgeries, what I did actually, I just patient came without dilatation. I used a Phenocan Plus on table. Still the results are same only. That's what I just saw Ramurthy doing last time in Jharkhand Ophthalmic Society. While doing the live surgery, I just used this one Phenocan Plus dilated. But full dilatation is very, very important.
After the surgery, any constriction of the pupil?
Yeah, I never do, sir. If you put it in the sulcus, I never do, because putting pilocarpine again, some of the patient may develop some sort of reaction and sometimes hike in the IOP. I think better not to put, just leave it like that.
And what OVD you are using, Dr. Kudlu?
Huh?
What OVD you are using? You using simply a Hilon type of thing, or just carboxymethyl cellulose?
No, normal carboxymethyl cellulose I am using. Some of the surgeons they use co-SU also, but sometimes if it goes behind the lens, going back behind the lens and again taking out, sometimes problematic, and the patient may develop increase in the IOP post-op. Best is, I think, carboxymethyl.
Okay.
Thank you.
Beautiful.